Hello everyone, today we talk about very interesting topic, common problems in residency or in medicine. So today's topic is asthma. So initially the history for asthma, you want to know about, is there any chest tightness? Is there any wheezing? Is there any dyspnea? What is the baseline asthma attack? How often does it come? Okay, these are the questions. Is it one time a week, one time a month? Is there any altered mental status? Is there any precipitant, any history of allergies? Okay, these are the things. Compliance is very important thing. So this is the history, okay? And dyspnea, and then LICORA, location, intensity, quality. Okay, this is the history type. Exam-wise, what do you do for exam? What do you think?
Exam-wise, you want to
do full exam, cardiac, respiratory, check is there any atopic dermatitis, is there any lymphedema, okay, this is kind of things. And then differential diagnosis, when somebody comes in with asthma, what is your differential diagnosis?
COPD, pneumonia, pneumothorax, PE, panic attack, CHF, and even GERD, bronchiectasis, okay, and even allergies.
Perfect. This is very reasonable differentials for asthma. Okay. Now we go to the lab. What are your favorite lab work that you would like to do? Labs that you want to do for asthma. What is a blood work that you want to do?
Well, it's important to get an ABG.
Okay.
First, but prior to that, I'd like to get a CBC, a CMP. D-dimers to rule out any PE.
Yeah, okay.
And we said ABG, right? To see if the patient is getting into any respiratory.
Sputum culture. These are X-ray, chest X-ray. You can do that. These are the things. And the other thing, the criteria. What type of patients you admit to the inpatient? What type of patient you admit to the ICU?
So the patients you normally admit to the ICU are those most likely status asthmaticus.
Yeah, perfect. Status asthmaticus, if they have impeding respiratory failure, if they have worsening fatigue, PCO2 more than 42. Someone or inpatient, usually someone who have frequent ED visits, someone who have been in the hospital in the ED multiple times in the past 12 months. Someone have low compliance. These patients, they may be a good idea to have them admitted to inpatient. And then how do you treat a patient with asthma treatment?
A patient with asthma depends on the stage of asthma, right? For if it's acute exacerbation,
acute. What is it? Yeah.
You want to do a supplemental oxygen, albuterol inhaler, and methylprednisone, which is a steroid.
So if someone in inpatient admission, the way you treat it, you treat it with methylprednisone, 125 milligram IV now, and then you do prednisone, 1 milligram per kilogram PO after that. So let's say somebody 60 kilogram, you just do them 60 milligram of prednisone daily after that. Okay. But if someone in ICU, then you give them higher doses. You give them methylprednisone 125 milligram IV Q6 hours, every 6 hours. Okay. Until they get better, then you switch to oral. You can even choose magnesium 2 gram IV over 20 minutes. Okay. And then you add antibiotics as well if you suspect infection. If you suspect infection. Okay. Now, after they resolve from their acute exacerbation, then how do you treat? If it's just mild, there are different stages of asthma. If it's mild intermittent, how do you treat it?
If it's mild intermittent asthma, you give them albuterol as needed.
Perfect, albuterol PRN. How about if it's mild persistent?
Then you do a fluticasone.
You can add fluticasone to that. What if it's moderate?
Then
persistent.
You do Advair salmeterol plus fluticasone.
Yeah, perfect. You add lava. Okay, so add plus salmeterol and add to the fluticasone. Okay. Okay, so you just add on there. How about if it's severe persistent? You give them albuterol plus higher doses of Advair, Advair basically salmeterol plus fluticasone, and you can even choose other medications you add to that as well, like for example montelukast 10 milligram PO, or you can some other immunotherapy sometimes, like if there's eosinophil is high and IG is high, you can do omalizumab or pemalizumab. These are other options. And then, what are the risk factors for asthma?
So the risk factors for asthma sometimes it can be genetics.
Perfect. Genetics, environmental as well. Okay.
And dust mites.
Yeah.
Upper respiratory tract infection.
Yeah, if there's upper respiratory tract infection, sometimes even aspirin, NSAIDs.
Yeah, and
exercise, it's like that. And then the patient admission orders, usually when the patient admission, usually you try, you do vital signs, you check vital signs, frequent vital signs. You can do oxygen as support, continue supporting oxygen. Diet, you do regular diet, and then you give them the methylprednisone 125 milligram, depending if they're inpatient or outpatient, and then you add the Doanep, Brio, Incruz in the hospital. In our hospital, that's what we usually use. And then you order a bunch of labs, ABG, CBC, CMP, chest X-ray. And once the patient get better, what would you do before they discharge the patient?
You want to do a peak respiratory flow monitor?
Yeah, so the most important thing, you want to educate them about diet, ensure adequate medication, and they have adequate medications, and make sure you can do a peak respiratory flow monitor as well, like as an outpatient. Educate them about the triggers and smoking. Education, basically. Make sure compliance and PCP follow up in 7 days. So in a nutshell, quick review. For asthma, usually history, you talk about chest tightness, medication compliance, allergies, atopic status. Exam, do regular exam, plus check if there is any atopic dermatitis, skin allergies. Differentials include COPD, CHF, pneumonia, PE. Labs, ABG, CBC, CMP, D-dimer, sputum culture. And if it's inpatient, you do methylprednisone 125 now, and then 60 milligram PO. For ICU, you do methylprednisone 125 milligram every 6 hours, and then you switch to PO, and you can add magnesium. If it's mild intermittent, albuterol PRN, mild persistent fluticasone, moderate persistent salmeterol, severe persistent higher doses of Advair, you can add montelukast or prednisone or omalizumab, and you discharge them after you educate them. Basically, that's a summary of asthma. Thank you so much for listening.